Good day, everyone. Welcome to today's webinar, Heart Talks, Navigating Vascular Aging for Heart Health, hosted by the American Heart Association. I'm Catherine Liao, Chief Strategy Officer at Cardiex, where we develop solutions that enable the measurement of central blood pressure and arterial stiffness indices at the point of care and at home. Today, I have the privilege of moderating a discussion on a topic of critical importance, that being vascular aging. We'll delve into what vascular aging is, why it's crucial to heart health, and how our understanding can lead to better health outcomes. Joining me is an esteemed panel of cardiologists, Dr. Sanjeev Bhavnani, Senior Cardiologist and Principal Investigator for Digital Health and AI Clinical Trials at SCRIPPS Health, Dr. Purwani, Director of the Cardiac Diagnostic Laboratory at Loma University Health, and Dr. McConnell, Clinical Professor at Stanford University. Now, I invite each panelist to introduce themselves and share their insights on why vascular aging should be a pivotal part of our conversation about heart health.
Hello, everybody. Thank you, Catherine. Thank you, American Heart Association. Privileged to be here. Mike Purvi to share the stage with you. I'm a clinical cardiologist at Scripps Clinic in San Diego. General cardiology, heart failure focus. I've been involved in the field of digital health when it was called wireless health many years ago, working on new product development and figuring out how do we use those as part of patient care. I have spent time at the Food and Drug Administration as a medical officer, working on digital health machine learning policy. Fascinating look inside the working model of U.S. healthcare, and now very interested in how do we move the needle on health and disease as it relates to cardiovascular care. I am a medical consultant and clinical officer at Cardiex, and interested in bringing new technologies like that towards patient care.
Thank you, Sanjeev. Hello, everyone. My name is Purvi. I'm an associate professor of medicine and imaging cardiologist at Loma University Health. So I am in the only blue zone in the United States and actually in the North America. And I really enjoy this intersection that I sit at, which is intersection of prevention and imaging. And as an imaging cardiologist with expertise in echocardiography, coronary CT, and cardiac MRI, I really enjoy trying to implement these non-invasive techniques to figure out where we can meet the patients and how we can implement prevention for our patients. So I really represent the clinician that takes care of the patients. I typically take care of various socio-demographic classes. I take care of the affluent population of Loma Linda, who are the blue zone population, but also not so affluent San Bernardino population, where I see different ethnic backgrounds. I also have an interest in women's health, so I see pregnant patients, that are women and have higher risk of cardiovascular disease. I evaluate them and give them their cardiovascular risk and put a plan in action for them. So I'm really honored to be on this panel, and I would share my expertise both as imaging cardiologist as well as a preventive cardiologist taking care of these various demographics. Thank you.
And I'm Mike McConnell, and it's a pleasure to be here. Thanks for the invitation, and with esteemed panelists. I'd say I'm probably a hybrid of Purvi and Sanjeev. Had mostly an academic career at Stanford, focused initially on cardiovascular imaging, but got more involved in blood vessel imaging, early disease detection, ran Stanford's preventive cardiology clinic, and then got exposed to the world of, and when I joined, it was mobile health that has evolved into digital health. So spent a number of years at several alphabet companies working on mobile and wearable devices for research and monitoring and early disease detection. And over the last couple of years have been advising several startups that are trying to combine, most recently, imaging and prevention and AI, and really bringing this health technology, into patients' hands. And it's also been a pleasure over now 10 years being on the advisory group for what we call our health tech advisory group for the AHA, and supporting the work of the Center for Health Technology and Innovation at the AHA. So great topic, and thanks, Catherine and Jeff and others for bringing us all together.
And let's get started. Thank you for your introductions. I'd like to first turn to Dr. McConnell. Your book, Fight Heart Disease Like Cancer, presents a compelling historical account involving President Franklin D. Roosevelt. Can you tell us what happened?
Hopefully people have heard this story, because ultimately it, led to the founding of what we now call the National Heart, Lung, and Blood Institute, and the origins of the Framingham Heart Study. But right, he had continuingly higher and higher blood pressure over his life and during his presidency. And at the time, it was just ascribed to sort of normal, healthy aging. I actually heard it recently presented again at a recent conference that, blood pressures over 200, what we would now call a hypertensive emergency, was considered sort of normal aging, but he developed heart failure and then stroke as a result. So so I think that triggered much more research and the understanding of issues like high blood pressure and other risk factors and lifestyle that we've now learned are critical for assessing risk, where we need to screen for and then often treat to really try to reduce the risk of heart attacks and strokes and other cardiovascular diseases.
That really, reveals a profound misunderstanding of aging and its impact on cardiovascular health, or vascular health specifically, doesn't it? I'd like to dive a little bit deeper, Dr. McConnell. Could you share specific examples from your clinical practice where vascular aging played a significant role in patient outcomes? And then after your response, I would love to hear the same from Dr. Purwani and Dr. Bhavnani to also share examples from their experiences as well.
Yeah, and I think vascular aging, I think, is a great term for really understanding that, the blood vessel is often where we think all these risk factors, some genetic that we're not always measuring, some behavioral that we're not always measuring, sort of all come together. And as blood vessels are sort of the critical component, not just for our heart, but for our brain and our kidney, all of our organs. So as our blood vessels age and are affected by these various conditions, they're big drivers of cardiovascular, kidney, and brain disease. I'd say, unfortunately, we don't, I think we're still at a phase where good measures of vascular aging that we can do early on and non-invasively, have been more limited. I'd say so the classic thing you could think of vascular aging that we use routinely in practice is as vessels are sort of damaged and aged, they calcify. So I think, many of us doing a coronary calcium scan as part of our sort of most typical way in people who have risk factors, and you're trying to help assess, are their coronaries aging at an accelerated rate to then warrant more intensive medical therapy. But as you know, calcification, the coronaries is a relatively late phenomenon. It's not very sensitive in women. So, I think while that is sort of a late stage vascular aging technology that we use, I'd say, in other patients where you see more in terms of their blood pressure and, as they have an increasing pulse pressure or more labile or more difficult to manage blood pressure, again, that feels like you're catching it at a later stage where it's harder to manage, harder to control their blood pressure. But certainly whenever there's evidence of sort of accelerated vascular changes, that really is an impetus to address more aggressive risk factor management, working more closely with patients around lifestyle interventions that we know can also attenuate vascular aging. So, as we'll continue to talk, I think we need more tools to see this earlier, where it's potentially more reversible and can mitigate the progression to, heart attacks, strokes, kidney failure, et cetera.
So I think, Catherine, you asked the examples, and I think as Dr. McConnell correctly said, it's like all these patients with accelerated atherosclerosis or arteriosclerosis. So in my clinical practice, I'll tell you, as I was mentioning, I see women. I remember this very distinct case of a 22-year-old woman with advanced SLE who had some, kidney dysfunction, came to hospital. This was her 5th admission in total for chest pain, first one at our hospital, and I happened to be the consulting cardiologist. And she had classic angina, but because of that age bias that we see, everyone thought it was pericarditis and kept discharging her from other hospitals. So we took her for cardiac catheterization, and she had significant triple vessel disease, advanced cardiomyopathy. We ended up actually transplanting her, and we wrote up this case in European, journal case reports. But I think in my practice, apart from the inflammatory disorders like SLE and systemic sclerosis, I also see this in genetic disorders like Marfan's, where they have this accelerated risk because of what genetics they have. Also, not to forget, the chronic kidney disease. So a lot of these patients, young patients can get chronic kidney disease because of the autoimmune phenomena, and they would come back with, valvular heart disease, significant atherosclerosis, cardiomyopathy. So I think that chronological age that plays such a significant role in all the risk factors that we look at, doesn't kind of give us that accurate and precise cardiovascular risk for these young patients, because their risk is often underestimated by these population health measure. And this is where I think vascular health is, extremely useful in younger patients, where you are thinking about their accelerated risk because you're looking at their overall profile. And to me, the way I think about vascular health is it's really that cardiovascular risk that is expressed in age. And, it is better than just chronological age or the risk factors that we traditionally use, because number one, when you look at a vascular age of a patient, the traditional risk factors are already taken care of because you're seeing the manifestation of the traditional risk factors. And number two, in contrary to the traditional risk factor, which fluctuate over time, this risk is constant. When you show this to patients as a clinician, it is very, very useful because they understand this language and they understand the concept of prevention.
Thank you, Purvi. And Mike, Catherine, it's a great question, right? And I think we all see it from a similar lens of the need to assess vascular health early, right? And then also with the eye of what can we do about it. In my practice here in Southern California and San Diego, not a blue zone as such, but still pretty beautiful, is in the East County of San Diego, bordering into the unincorporated areas, the desert zones, and where we really had an opportunity to start expanding, right? Catchment, right? Which I think now we bring in two And Purvi, I'm very glad that you brought up, the rural and the social determinants of health and the geographic disparities of just access. And I remember when starting, in this practice of seeing people, with, multivessel coronary disease as their first entry point into a cardiology clinic. Our large veteran group in this county, immigrant populations. San Diego is a repatriation city for war-torn refugees, and really, when you put specialty practices there, of course, you'll catch things that should have been caught before.
Mm-hmm.
And I remember, a mid-50-year-old Chaldean individual male with a calcium score of 15,000, and that led to our radiologists and cardiologists reaching out to their colleagues around the world to say, "Is that real?" Whether it be, systemic sclerosis, calcification or oxalosis, but it showed us that, access is very important, and understanding vascular health across where geographic divides exists, because that itself should be a risk factor for early onset, or what we contemporarily call the premature onset of cardiac disease. But it's corollary, which is accelerated, vascular aging, right? And so now, how do we do that in ways that can better understand risks in individuals and across, groups and populations through the tools that we have now, which is just access to good primary care, cardiovascular care, lipid testing, get your blood pressure checked once, right? And perhaps calcium scoring where available, but also look towards pragmatic, right? Because sometimes I would say on a professional and a personal note that I think when we all see individuals like that, we look at the failures of cardiovascular care, but also its opportunities, right? If now we're looking to bridge those gaps. But sort of a unique case that I remember is you bring up your unique cases as well. That prompts us to think differently.
That makes me kind of start thinking about, well, tools, right? All three of you have said we need to have better tools and technologies that can be leveraged to assess vascular aging, especially earlier. Perhaps each one of you can share one diagnostic tool or technique that you find invaluable in assessing vascular aging.
I think there are, it's certainly opportune now to use what we know is available and works and where there's data. And also embrace where there's debate, like calcium scoring, right? Of lipid profiling, of LPAs, of checking blood pressure, of doing glucose testing, really, getting what we have available to us, right? And implementing it in the best way possible for us to understand, risk. This also is important because I think in cardiology, this is a shared field, right? Primary care and family practice, we are upon the shoulders of those practitioners, right? That, are out there and trying to combat heart disease as frontline, and sending us the people that we think, we can treat and hopefully, prevent. But I think, as we have an eye towards, and I have to say from a passion point of digital health and machine learning, right? And we'll get there, right? But the pragmatist in me also has to acknowledge that we should, what has been done, over the past decade and longer, should be used as a catalyst, right, for driving change. And if we can do that now in a unified way in practices and in collaboration with primary care and for patients, now we can start looking at very new tools and biomarkers and devices and artificial intelligence, right, dare I say. But I think that's where we start. And but that's how I think we optimize right now.
That was excellent, Sanjeev. I think when I think about vascular health and how to measure vascular health, what we are doing is measuring characteristic of the artery, right? And I'm going to put my imaging cardiologist hat on for a minute. So I think you look at either the structural composition of the vessel, so whether it is coronary artery calcification, measuring the inflammation in the vessel, or the plaque characterization, right, on the coronary CT, which we love to do. Or it is the geometrical measurements, right? So what is the vessel diameter? What is the size of that vessel? What is that intima media thickening? Or the functional aspect of the vessel. So that's where, as Dr. Bhavnani was mentioning, the blood pressure measurements, what's that ankle brachial index, what's the pulse wave velocity, or the dynamic parameters like flow mediated dilatation of the carotid artery. Now, I will tell you practically in my practice, what is the easiest is the coronary CT and the coronary artery calcification. The coronary CT is right now not indicated because we lack the data to do, without symptoms. But, coronary artery calcification is what I use mostly. And then if patient has symptoms and you can get that coronary CT and examine the plaque, I think that gives me greater details on, vascular health of the patient. And of course, following that arterial diameter, size of aorta, size of other vessel, that can be incredibly useful. But I must say that the other parameters, although they are there, although there is literature, this world of atherosclerosis and arteriosclerosis, they don't talk to each other. And, we need to see kind of that penetration into guidelines for the clinicians like me to start using all the other parameters routinely in clinical practice.
I maybe have a little twist on the area that I've been particularly excited about, which is, I think Eric Topol had a recent blog post on, opportunistic AI or opportunistic imaging, where many times you're getting imaged for one purpose and it has the opportunity to pick up vascular disease. So actually colleagues at Stanford have a program going where if you happen to have a CT scan for other reasons, it will flag coronary calcification. I think many of us, historically, if we heard someone had a CT scan for one purpose, we would look to see, is that a way to pick up early vascular changes? Certainly ultrasound and the advent of point of care ultrasound has made it much more user-friendly to pick up, and even in the ESC guidelines, picking up carotid plaque as an indicator for more aggressive therapy. But I think, one of the stories or sections in the book talks about the opportunity for mammograms, and there are companies with AI tools to pick up breast artery calcification, so that, right, a woman getting her regular mammograms, there's an opportunity for early detection of vascular aging and vascular changes. There's obviously been a lot of interest over the years in wearables with things like pulse wave velocity and vascular measures that can we get to a point where that's easy to do with our wearable devices or through a phone camera. And I think there's still some very interesting opportunities there. And obviously I'll talk a little bit about my particular current interest around retinal imaging, but that classically it's even still in the ESC guidelines of fundus, looking at the fundus in a newly diagnosed hypertensive patient. I wish I could say I was still good at doing that regularly. So I think this is one of the areas where, leveraging the technology to augment what humans can do, can play an important role.
And I'll just build on what Dr. McConnell said about retinal imaging. So perhaps you can talk a bit about the BioAge from Toku, which is one of the companies that you advise. And then for Dr. Bhavnani, that's chat about reference age from Cardiex, which is also now the representation of a heart age.
Yeah, so one of the companies I work with where I'm chief health officer is called Toku. Actually, back in 2018, when I was with Google Alphabet, we had applied AI to the retina initially to predict various cardiac, sort of trained on each of the cardiac risk factors that go into your risk score, but then showed when you combine all those AI models, that AI, the retina, could predict that 10-year risk score very similarly to if you had all the blood pressure and glucose and blood pressure and cholesterol and age and sex. So we've applied that and have been putting that into a product to help with early assessment for advanced cardiovascular risk. And as Catherine, you noted, in many ways, an easier or better way to communicate that is, we do have in development giving, do you have that elevated risk score? But the bioage is really to better communicate, where are you on the spectrum relative to others your age? So we can look at AI of changes in the retina and then, say your retina looks much closer to the retina from our large data set of someone younger than you or older than you. So very much as a way to stimulate, lifestyle improvements to help improve your bioage. And not surprisingly, more advanced bioage, when we've done several research studies on that, you're more likely to have those cardiovascular risk factors of high blood pressure, diabetes, or chronic kidney disease. So it's both a stimulus to help improve like AHA's Life's Essential 8, but it's also, we hope, a stimulus to make sure you get checked with your doctor to, you make sure you don't have some of the risk factors that not everybody's good at getting checked regularly.
This topic of communicating information to people who have higher risk, and that paper, right, the Blaha paper from Hopkins on MESA was done specifically for how do you communicate, risk in a fashion of coronary risk, coronary age versus chronologic age. And it's just that, bringing up as we were discussing before, as we, looked at new methods for measuring underlying physiologies and target organ damage, but also how we see, the move of how we communicate that information on diagnostic tests that we do, right, to patients and people so that they can better understand and create action from it. And so similar, Mike, to your developments at Cardiex and with the sphingomycor device, reference age, right? The device itself is a blood pressure device. It takes a brachial blood pressure from the arm. It deflates and reinflates to record brachial waveforms. And so using a transfer function, it creates aortic waveforms from central pressure done through a peripheral device. And where reference age has been generated and evaluated was in the ACCT trial, the Anglo-Cardiff collaborative trial from years ago of 10,000 individuals, a longitudinal assessment to look at risk over time. And in 4,000 healthy individuals, it also had the measurements of pulse wave velocity using the device, pulse wave analysis, was to calculate what a normal reference range is for vascular health and vascular age. Takes into consideration important variables such as age, height, gender, that we know is different across, across genders, but to now measure wave propagation parameters and underlying physiologies of arterial function and how pulse wave analysis, augmentation index, and the reflection of the wave back to the heart is done to compute a reference vascular age, of arterial age in individuals. Because creating reference ranges is, of course, important as we look to compare what an individual's reference age is to what their vascular age may be through doing new testing, as Mike, you brought up, as with new devices, with this sphingomycord technology. But how we do this with reference standards and now look to augment that information to people who undergo such testing.
Now, earlier, genetics was brought into the conversation, and I thought it's probably a good time to bring that back in, since it greatly impacts cardiovascular health. Dr. Bhavnani, could you explain the role in that genetics play in vascular aging and how this influences the personalized approach to treatment and care?
I think in general, genetics, of course, has a role, right? And if we now look towards the future of better understanding early onset atherosclerotic disease through genetic analyses, I think there's very interesting data out of Broad Institute and others that are looking at what are the genetic determinants of early onset heart disease and vascular disease. But in addition, what role ethnicity plays in that, and what value lifestyle, exercise can have in mitigating individuals who have a higher genetic risk of cardiac disease. So I think now as we look at the role of genetic testing, and I have not done genetic testing in clinic for an assessment of vascular health, but have done it, of course, in cardiomyopathies and for lipid testing. But as Jeff Ginsburg had once said, that there's a lot that can be learned from genetic testing over the past 20 years with its application now to how digital and new innovations can measure something. But how we can use genetic testing for vascular health, I guess, largely remains to be seen right now. I'd love, Mike, and Purvi, your opine on this, but there are opportunities to better now do research studies, look at precision modeling, employ artificial intelligence approaches to analyze genetic mutations, and so how we do that will be very exciting. I wonder, in the same context, how this, and as we're also looking at a holistic view of diagnostic testing and individuals' risks, of how we may also look at the combination of genotype phenotype now through new technologies, where we previously we weren't able to look at early onset phenotypes and may have missed where the association was present but didn't have high enough fidelity tools in order to capture it or measure it. But I guess more a question as we look at the opportunities, but I do see value in how the cardiovascular community can catalyze and galvanize genetic testing for vascular health.
I think that was spot on, Sanjeev. I think if we look at the cardiovascular disease or any of the cardiovascular disease risk factor, most of them have polygenic background. So if we put all those monogenic conditions that cause, severe familial hyperlipidemia, premature coronary artery disease, and premature death, then you are talking about this interplay between, the lifestyle, the environment, and, all these dozens of, polymorphism that can come with that, right? So I think that you're absolutely right that there is much more to be explored. I will mention that in the blue zones, the studies from Icaria that had come out, truly the vascular health is much better for any given age compared to the general population when they measure the pulse wave velocity. That tells you that why blue zones have probably at a population level same risk factors and probably same distribution of the genetic disorders that people are born with, yet these people live longer and they have much better vascular health. That tells you that interplay between the environmental and, more importantly, lifestyle, which is why, again, determination of vascular health beyond genetics is so essential.
The genetics really is one component to a risk. But there is a lot of very strong data that even those at higher genetic risk, that the benefits of healthy lifestyle are just as helpful, even in those at higher genetic risk. I think it's an interesting question too, because we still often have situations where, as you're saying, someone has some family history, but not sort of the obvious familial hyperlipidemia, where you're trying to get an assessment of what's their combination of the easy things that you can measure, their genetic risk, and then all those lifestyle and behavior, which, yes, we can measure more now with our wearable devices, but typically you don't really have a good idea of what that lifetime exposure to either good or bad behaviors has been. So that's why I probably am still somewhat old school, and like I try to let the vessel tell me what's that accumulation of everything that's been happening. And so if your vessels still look good, that can be a very positive aspect to it. So yeah, I think, leveraging your vascular health or your vascular aging as a way to see how all these things come together. But with, all the tools we have for earlier detection, monitoring, and then helping to either reverse or attenuate, any vascular aging, again, with the ultimate goal of avoiding the clinical events of heart attacks, strokes, heart failure, et cetera.
So I think this is now a really good point to transition to the Q&A for this webinar. I just want to pose one more question, a final question to the three of you. What advice would you give to fellow healthcare professionals and the general public in promoting vascular health and mitigating the effects of vascular aging?
Okay, so I'll start with the clinician first. So to the clinicians, I'd like to say that, look, prevention is the coolest intervention that's out there. And we are sitting in a very a major paradigm shift in healthcare. And I cannot be more excited as imaging cardiologist, because now non-invasively, without poking a vessel, you can actually detect changes in the vasculature that are detrimental to cardiovascular health in a patient way early than we could ever do. Right? In last 20 years have been really transformative. So take advantage of that. Start detecting these things for your patients. Start treating your patients early, so that they can avoid these, cardiovascular events later in life. To the patients, I would say that, I struggle with patients sometimes, because I still think in our society, symptomatic relief becomes the main reason why you go to a doctor. And I do think that there is so much we can achieve by, this combining good lifestyle, exercise, and seeking advice from your physician, before the symptoms develop. And being compliant with that advice. So although the guidance from all this, data that we are collecting, or, it's not perfect, right? Like particularly in a longitudinal manner, it's not perfect for our patients, but just detecting that vascular health and realizing, how ahead or behind in the game you may be compared to your peers in the same age group is so essential. So ask those questions to your physician, get tested, know your blood pressure, know your glycemic index, know, your BMI, and start putting work towards it.
I think I should have had you write a big chapter in the book that I did. But I think you hit on a lot of key messages, and the reason I wrote the book was really mostly to try to reach people, patients, that we have a lot in prevention. I think people have heard a lot about heart disease prevention, but we now have all these great tools for early detection of, as we don't all age at the same rate, and and we can even try to do healthy behaviors, but over time, these risk factors, our genetics, et cetera, catch up with us. And but we have the tools to know that early. And if we see it, we have very safe, inexpensive medications to lower your cholesterol, get your blood pressure under control, help with your blood sugar, so that you never have to have a heart attack or stroke. And so a lot of the overarching theme of fight heart disease like cancer is it's killing more people than cancer. It's just as serious, and if in many ways, sometimes more immediate and sudden in its impact. And just like for cancer, we've got good programs where you understand you need to get screened, and if you find an abnormality, get it treated. And so really trying to expand that messaging to patients. And certainly for providers, it's really trying to up their level of concern. And I know doctors are always busy and patients have lots of issues when they first come in, but know your numbers, as you just said, get the numbers checked, do the risk scores. If people have had imaging, make sure you note that there are vascular changes, or, when people are at risk, get a calcium scan or beyond. So, we've got these tools to, I think when a patient has a heart attack, to me, that's like a plane crash that, what did I do wrong? We have to change that mindset that we have the tools to prevent heart attacks and strokes, and we should be, using everything in our power to fight it.
It's like to follow now and and round up, but to take, Mike, your analogy of a book, right? And Purvi of the audience says, I think education, right? Being a take-home message that for all of how do we educate, the importance of vascular health now in a way that leads to, action from those people where it's valuable, our patients, our people, our consumers, but also those who now deliver it. And so as a call to our younger physicians, right, that think outside the box, right? Think about what else can we do, right, in order to understand vascular health as a systemic process, not just cardiovascular, right, but systemically to people and patients. Really have them the opportunity to pull us forward, know about innovations, right? Read about it. There's so much available now to measure arterial health, to measure pressure, right? To take ownership and know that there are very good opportunities now for people to do that. And to our societies and to our governments, Purvi, right? To planetary health, right? To push, right? That big change is needed in order to incentivize, to deliver, to change the practice, right, of cardiovascular medicine that moves from that equally is from cardiovascular disease and prevention. And it's in order to, I guess, the cardiologists of the future are those that are not treating heart disease, but are very good at preventing it. So hope going forward that this field can evolve and change.
Thank you to each of our panelists for sharing their valuable insights and expertise on vascular aging. I mean, here is lots of advice to the cardiologists of the future, especially. Today's discussion not only highlighted the complexities of this field, but also underscored the exciting opportunities for innovation and personalized treatment strategies. Now, we would love to open the floor to questions from our audience. Please feel free to ask any questions you might have about today's topic or any other inquiries related to vascular aging and cardiovascular health.
Amazing. So much great content and so many good discussions. My name's Jeff Makowka. Unfortunately, Catherine, due to some technical difficulties, isn't able to be here for this part of the presentation. but I'd like to introduce myself and thank our panelists for participating. I'm with the Center for Health Technology and Innovation at the American Heart Association. We're very proud and pleased to be able to convene webinars such as this to talk about things that are the cutting edge, both in the treatment and the prevention of cardiovascular disease and stroke. You know, the AHA has been for 100 years pioneering innovative approaches to heart and brain health, continuously pushing the boundaries of medical science and public health. This legacy is forward-thinking and embodies the Center for Health and Technology and Innovation. The CHTI, as we like to call ourselves, spearheads innovation at the nexus of science and technology, collaborating with health tech innovators who share our mission to enhance patient outcomes, lower costs, and reduce barriers to care. So that's what we are and why we're here. We're so excited to now take some questions from both the attendees that are listening and even within the panelists. So let me check our Q&A area to see if anyone has posted any questions. We don't. Thankfully, I've been able to come up with a couple just to get us started. So panelists, you know, during the earlier part of the discussion, the thoughts around calcium scores came up quite frequently. And I think the way I listen to you, it still seems like there's maybe some controversy or doubt about the effectivity of calcium stores. Can they be used to come up with vascular aging? Who would like to start?
I'm happy to jump in if something I think about a lot. So, I mean, I think one key thing to reinforce is they're very much part of the guidelines. You know, if anyone wants to reach out later and, you know, get the specific figures from the latest guidelines, I think one I'd refer to you. There's a, you know, recent on sort of a clinical decision support around prevention therapy, where it maps out, you know, the best way to use coronary calcium scanning. But around how it relates to sort of vascular aging, I think one of the things that I very much use that helps to communicate it to patients is I'll take the calcium score and I'll put it into the MESA website, which then gives you sort of where for that particular, so it's different in, you know, based on men, women, age, and race, race ethnicity. So when you put those in with the specific coronary calcium score, then you get, you know, where are you relative to others your age? You know, and so it's actually part of the guidelines is not only like if your score is over 100, that's higher risk, but if your score could be below 100, but greater than 75th percentile for your age. So, and I think that's particularly helpful to communicate with patients that, you know, you're either 0 or that score where that relates for someone your age, whether it's significantly lower or higher. But certainly others jump in, and I think I had a follow-on question for panelists if we have time for that.
I think you're spot on, Dr. McConnell. I think what helps human beings is not just the absolute value, but the comparison, where we stand, right? So I think that kind of communication with the patients kind of makes them understand what their risk is. So I find it useful to compare it with the age. And I generally tell them that, look, if the calcium score is 400 or more, you are 80 years old or more, right? I think saying that, I think I find it a very good population based tool, right? Like, you know, when it is high and bad and you can show it to the patient, it works. But when it is negative, I'm not certain, particularly if there are other risk factors that particular patient has. So I think that's the challenge when it comes to, you know, when we are talking about vascular health, to me, where it is more applicable is it in younger patients where other risk factors or other risk scores are not matching, and I'm trying to determine their overall cardiovascular risk. And unfortunately, it may not be that useful in young patients, as we all know, because the process takes time and, you know, it's not that useful. So that's where I find that challenge, what other things we can utilize. to determine that younger patients, vascular health.
Well, you predicted my question, because I was literally going to ask both of you what you think about, this challenge that calcification is, it can be useful for when it first turns positive, but in younger patients, particularly in women, it can be quite delayed, and so there's a big sort of missed opportunity there. So what do you think about other tools for earlier, and particularly in women, and then also for monitoring? Because it's not, once it turns positive for a coronary calcium score, it's usually not particularly helpful in terms of monitoring on therapy. And so yeah, I thought I'd give you those easy questions.
So I think as in the webinar we discussed, right, there are like these components. One is atherosclerosis, another one is arteriosclerosis, and somehow the field don't talk to each other, right, so far. So I think that in younger patient, that arteriosclerosis, how is the artery, the tone of the vessel is responding to the changes that are happening, that might be useful, right? So that's where the blood pressure, the, pulse wave velocity, etc., come handy, because all the other tools may not be that useful. The process of atherosclerosis may not have set in, depending on which patient you are looking at. Now, there are some patients, like, I give an example of the patients with, advanced CKD or the autoimmune disease. I personally find, again, going back to the, the structural component of the plaque, doing a coronary CT, particularly if they have any symptoms, and finding if they have soft plaque, if they have vulnerable plaque. I find that useful, but again, we know that, likelihood of us doing it in an asymptomatic patient is very low. And all of these patients, even if they are asymptomatic, they may have, a risk that may be higher than the general population. So I think kind of utilizing the tools that are out there that we discuss in the webinar and coming up with a plan for those patients can be useful. I don't know, Sanjeev, what thoughts you have?
No, thank you, Dr. Purwani. Thank you, Dr. McConnell. How upstream can we go, right, on being able to assess underlying physiologic risk, and then as it relates to the acceleration of calcification, of atherosclerosis, of arterial sclerosis, and see it even in individuals, but in populations, in Southeast Asians, in Hispanics, in African Americans, and how can we develop, and what are the evidentiary requirements for new biomarkers as they pertain to vascular tone, vascular health, of flow, pulse wave velocities. And that certainly is an area where, how we do that as a structure in clinical medicine, right? In whom do we use these measures, and what does it inform towards better risk stratification? I think your question, Dr. McConnell, on how does it change over time is something, as all clinicians and the patients that we serve, what would be required for us if a new modality or a new marker informed an earlier treatment decision? What would be necessary for us then to infer that a change has occurred? Is it a repeat measure of the same modality, or is it now using a more precise, a more anatomic, functional modality to see change over time? Maybe that's where we bring together the markers and the potential for it to be used in treatment decisions.
Yeah, and I think you bring up a great point. We often sort of either think of very structural technologies or functional technologies. Certainly, you've been indicating that CT angiography, there's a lot of interest and a lot of research, going on now, where you can look at changes in athero volume, burden, plaque characteristics, as maybe, a very helpful way to follow change, particularly on, if they're either lifestyle or preventive interventions. right, we also, historically have had data that things like brachial artery vasoreactivity, the sort of classic early endothelial dysfunction indicators can show improvement with, lipid lowering or other lifestyle interventions. And so, you guys probably know more than I, some of the data maybe around pulse wave velocity and things, but the functional improvements as well as structural improvements, have been seen. And right, it would be ideal to have ways to follow both.
Excellent. So we're running close on time, but I do want to throw out one question. I don't say it's quite a lightning round, but I would like to get your opinions on the utility of central blood pressure. Why isn't it leveraged more clinically? What are the shortcomings? What are the advantages? And how does that relate to the rest of the conversation? Dr. Raj. Oh, I'm sorry. Who wants to grab it first?
I'll pass the baton to you too, because it's a domain area of our interest here to do it. Please, either Purvi, your thoughts would be greatly appreciated.
I think it's a great tool. I personally, as a clinician, I do utilize it, and I order what is clinically available to me in our practice, which is 24-hour monitoring. I personally would tell you that I have not tapped into all the, great tools that are out there. And this webinar kind of opened my eyes. I was brought in as the clinician giving the opinion on what is going on in the community. It is hard, right, to, the time that is given to us to take care of a patient and what all information you can derive. So I think I use it, but I haven't used it to you are absolutely right. Whoever asked that question, the central blood pressure has great potential. I am not sure clinically in, the practices around the United States, or for that matter across the world, how much it has been utilized.
Yeah, I'll add that I think there's a lot of very strong research that central blood pressure over sort of standard brachial artery blood pressure and other, markers of vascular stiffness or, vascular aging have been demonstrated in things like Framingham, research study and other studies. The challenge has been that it's not something that is then routinely available, in clinical practice or to patients. And then even though there's a good body of research evidence, we haven't seen it come into guidelines of, what are the best metrics to use and how do we use them to help, adjust our therapies accordingly. I think for many of us, we've often used these sort of very surrogate markers of patients who may, as I mentioned earlier, have, high pulse pressure and labile blood pressure issues, or that, we are often use these other indicators of more vascular dysfunction or vascular aging as to be more aggressive in trying to get blood pressure under control and, add further, add further agents when necessary, because we often have patients who are at that sort of borderline level. And so looking at other indicators of higher risk to say we need to be, more aggressive with our preventive therapy. But probably a big limitation is, how do we do more research to get those kinds of metrics and which ones into guidelines to, to show that they can help guide care better?
I think that remains the challenge with all the markers that we are talking about today, right? Like where exactly you have one data point that you can probably, start the treatment, but what happens to the longitudinal follow-up of that patient and how do you guide care from that? So I think that if anyone listening needs any research idea, it's a very fertile field and a lot to be discovered there.
No, and absolutely, if I may, summarize here on, its application, but why also not used clinically? Absolutely, as a marker, if we move beyond single measurements to now a multimodal approach, right, is how we assess risk, to not recreate that wheel, but how do we augment that? Right now, as the future moves forward with technologies and analytics that are available that characterize these markers, biomarkers of risk, how do we integrate it now? There is a component here on the clinical implementation, as we said, through guidelines, but also in education of future providers and ourselves on the value of such markers like central blood pressure. How might it inform earlier risk stratification in people whom otherwise might be classified as low risk? But that evidentiary and guideline-related approach is definitely needed, and how we do that now through the lens of educating and engaging healthcare professionals and the patients is maybe a translational opportunity for the next few years.
Wonderful. Yeah, I think we could have a whole nother webinar just on guidelines around novel metrics and markers and how to codify those and disseminate that information and guidelines. But unfortunately, we're at time, and so we'll have to end right now. But I want to thank the three of you for participating. This has been fabulous. We thank you so much for taking the time and sharing your thoughts and your wisdom on these topics. And we hope to welcome you back on a future webinar. Thank you so much.
Thank you, everybody.
Thank you.
Thanks, everybody.